So we go ahead with the next extremely important talk of emergencies associated with corneal transplantation, mission graft survival. Dr. Rajesh Fogla, please.
Thank you, Dr. Radhika, and I thank Dr. Bhavna Sharma for also including me in this instruction course. I have no financial interest to disclose. I'll be going through some of the clinical scenarios that you face after corneal transplantation, where proper intervention is essential for maintaining a clear graft and ensuring that the patient has a good visual outcome. The commonest complication that you can encounter, or which can be encountered by the follow-up ophthalmologist after a corneal transplantation, is loose or broken sutures. These loose or broken sutures can result in vascularization, can result in infection. They can also induce a stromal melt. Other than that, in a full thickness penetrating keratoplasty, all these things can also result in induction of a endothelial graft rejection. So the suture removal is essential, and it's actually easier to perform when you're dealing with interrupted suture. When you have a continuous suture like the image below, where one loop of the suture has given way, then to remove the suture, especially in the early post-operative period, within the first 6 months, can be a little difficult, and often the follow-up doctor does not remove the sutures, and the patient has to wait till he goes back to the primary surgeon. Topical antibiotics are usually prescribed to prevent any secondary infection, and if you're dealing with a full thickness graft, sometimes you have to step up the use of topical steroids because of the risk of inducing an endothelial rejection. So if the patient has been using steroids once or twice a day, when you have a loose suture, you're doing suture removal, you can just step up the steroid frequency to thrice a day for a couple of weeks and then bring it down back to the maintenance dose. Now, depending on the timing when the patient presents with loose sutures, you may decide whether to just to remove the suture or to go ahead and re-suture as well. Increased risk of having loose sutures, you can see that in pediatric cases, patients with allergic eye disease, or if the primary surgeon has taken sutures which are quite superficial, these sutures can also result in early loosening. So these are things that you need to be careful and you need to watch out for. The other suture-related problem that your patient can present with in the later part is that they can present with some amount of haziness in the peripheral cornea and lipid keratopathy from vascularization. This is commonly seen with lamellar keratoplasty, where there is an interface, and sometimes the patient waits till the central cornea is involved before they present to you. Use of topical steroids can reverse, but it takes a little time. Again, it is more common in eyes with prior history of allergic eye disease because they have a very active ocular surface, or with patients with lid margin disease where you can have surface inflammation which can result in vascularization. At the peripheral, this kind of situation of vascularization and infiltration often has to be differentiated from herpetic stromal keratitis as well. And suture removal can be performed, but I would institute the therapy earlier, the steroids, and then you can go ahead and do the suture removal under topical antibiotic cover. Also, you can get with the loose suture or broken suture, sometimes you see patients with central corneal haze swelling, which can be a stromal rejection as well. Especially with lamellar keratoplasty. So in this scenario, you use topical steroids. Again, more common with allergic eye disease. Again, you have to differentiate with herpetic disease, in that you can have the primary indication for which the corneal transplantation was performed, or if the patient has had prior history of recurrent attacks of redness. Suture removal, again, if they are loose or broken, they can be performed. The other emergency that is very important in the clinical scenario is endothelial graft rejection, more common in penetrating keratoplasty compared to endothelial keratoplasty such as DSEC or DMEC, where the risk of having an episode of endothelial rejection is almost 15 to 20 times lower. The typical symptoms of RSVP, redness, sensitivity to light, visual disturbance and pain is what you should look for. It can be managed with frequent use of topical steroids, usually full-strength steroids like prednisolone. If the patient presents relatively early, IV methylprednisolone can be given to try and reverse the graft rejection. You need to differentiate from viral endotheliitis, where the keratic precipitates will be distributed across the cornea and not limited to the corneal graft alone, whereas in endothelial rejection, you will find that the keratic precipitates will be only within the graft. And a lot of times with DSEC and DMEC, the clinical signs of symptoms of rejection may be much milder, so you have to actually go ahead and careful slit lamp examination can help you identify the condition. And in the long term, besides using the topical steroid, you can use them frequently, but topical tacrolimus is quite useful to provide relief and also to reduce the risk of a subsequent rejection episode. The other thing that's post-operatively you can see, which also associated with loose sutures, are epithelial defects. And if you don't treat them properly, you can end up with corneal melt, or they can heal with scarring, which defeats the whole purpose of doing a corneal transplantation. Etiology can be pre-existing limbal deficiency, allergic eye disease where you have a lot of large papillae under the upper eyelid. You can have neurotrophic component to it, which also reduces the rate of epithelial healing. And lid disorders, which result in exposure or lag ophthalmos, can also be the offending reason why your epithelium is not healing. You can manage by putting a bandage contact lens or an amniotic membrane transplantation or doing a tarsorrhaphy. You have to treat the underlying condition to improve the epithelial healing. And while the epithelial defect is there, you need to prevent any secondary infection. Infective keratitis, especially recurrence of herpetic keratitis, can occur on the corneal graft. It's important to stain and see, because if you don't stain, sometimes you can miss out a recurrence of the herpetic keratitis. And the typical appearance, the pattern that you see, often helps you in clinically diagnosing these conditions, managed with topical antivirals, and later on you have to give systemic antivirals for prophylaxis to prevent recurrences. And if a patient is not suitable for long-term oral antiviral prophylaxis, there is a role of topical ganciclovir gel that can be used. The microbial keratitis can also occur. It can have an early or delayed presentation. You need to rule out donor-related issues because sometimes you can have donor contamination, which can present both especially for lamellar procedures, whether it is anterior lamellar or an endothelial keratoplasty. And if you feel that is donor-related, then an exchange of the donor should be done in the early post-operative period. Appropriate antimicrobial therapy should be instituted rather than just doing an empirical therapy, because you need to know what is the clear offending organism if you want the graft to survive. And if it is not getting better, then therapeutic keratoplasty has to be performed. You can get stromal melt, which can be infective or immune melt. It can result from non-healing epithelial defect or loose sutures which have not been removed. Underlying systemic disease should be ruled out, especially collagen vascular disease. You need to suppress the inflammation, restore the surface integrity by doing amniotic membrane transplantation. And once that is done, then you can think about doing a repeat corneal surgery. Like in this patient who presented with corneal melt after lamellar keratoplasty, corneal thinning, we were able to go back and do a repeat lamellar keratoplasty and improve her eyesight. Trauma, blunt trauma can result in wound dehiscence. It can happen both after penetrating or lamellar keratoplasty. Often the patient presents, the clinical scenario would be a wound gape with loss of the lens, the iris prolapse and vitreous. So you need to do a primary wound repair, and later on then you evaluate. Sometimes they need a secondary procedure for any other complication that would have occurred. And the visual outcome in this scenario depends on the damage from the primary trauma. So this is a case of DALC where patients sustained a trauma, had that kind of a picture where they did a primary repair, following which later on we did an anterior vitrectomy and a secondary IOL implantation using the Yamane technique, and she recovered 6/12 vision. So basically, in conclusion, these are some of the clinical scenarios that ophthalmologists can face in a post-cornea transplant patient, and it's important that you can do some of the measures that I have mentioned in my talk, and at least for the initial part, till the patient goes back to the primary surgeon, so that the valuable time is not lost, and the appropriate treatment that's instituted right at the beginning can help the graft to survive. Thank you. Thank you for a patient hearing.
Thank you so much, Dr. Rajesh. And that key message is what really is important, that any ophthalmologist, if a patient comes to you, please intervene as Dr. Rajesh had shown for the various conditions, because that can go a long way in getting the graft to survive.